And that's for sure. That is for sure. All right. Well, while I'm getting everything pulled up here, anybody do anything interesting over the weekend? Anything cool? Nothing thrilling?
Nope.
Is that good a weekend, huh? Well, hopefully you did as little as possible. That's sometimes the best kind of weekends where you don't do anything.
Just watching these Astros.
How'd they do? I didn't even know they were playing this weekend.
They actually lost last night. Started a new series, but that's cool. Another game tonight. We'll see how it goes.
Oh, dear. Okay. Hopefully it goes better for them.
That means no free Chick-fil-A.
Not the biggest fan of Chick-fil-A anyway. I'm like,
I didn't know that was a
chicken
thing.
sandwich. If I'm going to buy a chicken sandwich, I'll just go get the one at Popeyes, which in my opinion is much more superior, and it's nice and spicy. Or the Whataburger. Whataburger now has a spicy chicken sandwich too that is really good. I had over the weekend. You get a lot more too. And Chick-fil-A is okay, but I feel like I pay too much for nothing when I go there. When I get my kids the chicken nuggets, they're like this big. And I'm like, dude, I spent $8 on like bird food. So that's my opinion. It's pretty, I mean, it tastes good, but
I don't know. I've only had Chick-fil-A like once. That's like purely a Texas thing.
Hey, for me, it's all about the Whataburger. I didn't appreciate Whataburger until I moved here, because when I lived in Lake Charles, there was a Whataburger right next to my university, and I didn't know what it was at the time, but all I knew about that Whataburger was that no one ever ate there. In fact, I always made the joke that had to be the easiest place on earth to work at because they never had any customers. But they just sat around all day chilling and hanging out because no one went to that Whataburger. So I just assumed Whataburger was like the worst fast food on the face of the earth. And of course, when I started dating my wife, I was telling her about that. She's like, no, don't you know Whataburger's like a Texas staple? It's like the best fast food around here. You got to try it again. I said, okay, I'll give it a try. Ever since then, I've been hooked on it. We go to Whataburger at least once a week, it feels like. It's like our favorite fast food. So as far as that Lake Charles Whataburger, it ended up going out of business and became a Starbucks, which they get a lot more business there than the Whataburger ever got, right next to the college. So that was my first exposure to Whataburger. I had the assumption that it was the worst place on earth to eat because no one ever ate there.
Is your hometown okay?
Huh?
Is your hometown okay?
Yeah, they had a lot more flooding this time instead of wind damage. So that is, I mean, a lot of people's homes got flooded, kind of like Harvey. Unfortunately, not quite as bad as Harvey, but they still got a lot of water in their homes. It was more so the people that already had damage from the wind got a lot worse because they already had holes in their roofs and there's always debris floating everywhere. So it wasn't as devastating as Hurricane Laura, but it still did a lot of damage overall. So keep Lake Charles in your prayers. They need it. They definitely need it. My parents' house ended up okay, thank goodness. They made it through both storms okay. So thank God for that. And my sister as well. But a lot of people were not so fortunate. So definitely keep them in your prayers. All right. Javier, I have never tried In-N-Out Burger, but I hear it's good. Yes.
You've never had In-N-Out Burger? How you've never had In-N-Out Burger?
I've never had it. No, there's not one close to where I live, so I haven't had a chance to try it.
All right. I don't think In-N-Out is good as compared to Whataburger. Just saying.
That's because this is a Texas thing. In-N-Out Burger is like purely Californian. There's only 2 in Texas that I know of.
But like, it's just the animal style fries. People say that it's good. It's just too much.
Well, I'm going to have to just sit back in here and let you guys have a debate, like a presidential debate here on the best burgers. I'll be the moderator. You guys can have at it.
I'll be Kanye West.
All right.
He's going for VP, right? That's who I'm going to vote for.
All right. Definitely get out there and vote, guys. It's some of our only freedoms we have these days. And get out there and exercise your right to vote. That's coming up really soon. Always encourage people to get out and vote, no matter where your stance is. Get out there and voice your opinion, for sure. Very important to do that. All right, so let's get going here, guys. I believe this is where we left off. We don't have much further to go for this chapter, so we're going to wrap this chapter up, I hope, today. And we have one more short chapter on Wednesday, and then we'll have our test on Friday. Everyone's talking about spicy chicken in the chat. Yeah, I made myself hungry talking about it too. I agree. All right, so here we go, guys. So we talked about all the oxygen methods of delivery, some of the emergencies related around oxygen, that proper care of oxygen tanks, so on and so forth. And I believe I already stated this, guys, but obviously when you get in there, if you're assisting a technologist, assisting a nurse, doing your chest X-rays, whether it's in a room or a portable X-ray in the EC, under no circumstances should that oxygen be completely removed unless you actually speak to somebody first. Very, very important. Don't ever walk in there and just rip that thing off someone's face, take that mask off. It's all about that communication. Once again, make sure if you do so, which I encourage you to do so, because like we talked about, these devices will show up a lot on the X-rays. Make sure you are consulting the correct person, whether that's a doctor, a nurse, respiratory care person as well. Anybody within the vicinity, just make sure you're communicating that properly. And then, of course, this is not on my PowerPoint, but I do recommend if you touch that device on their face at any point, document it when you're done with your exam. You always want that nice paper trail with everything you do, just to cover yourself properly should some kind of emergency arise, should something happen. At least you're covering your tracks, because I think I've talked about before, people love to blame radiology for everything. We're an easy scapegoat for a lot of things that go wrong, but I encourage you to always make a paper trail and defend yourself in case that does come your way, because those nurses love to blame us for everything. Don't let them get away with it. Don't ever let them get away with it. It's fun to throw it back in their face, I will say, which I have done quite a few times myself. That's going to be some of my stories coming up when we get into some of our other classes. I've had some epic battles with some nurses, guys. Some very epic battles. And when I used to be charge tech, I used to argue with them on the phone, holler at them. It's fun times, fun times. Okay, so we're going to move on from respiratory care to a little bit of these chest tubes and lines. We talked a little bit about the thoracostomies in the last chapter, or on previous chapters, I'm sorry. We're going to talk a little bit more about those again. It's going to be a little bit of review. See, everything's cyclical. Once again, it comes full circle. All this stuff repeats quite a bit. We're also going to add to that list our endotracheal tubes, shortened to ET tubes, and our central venous pressure lines, the CVP lines, which will be the first ones we talk about here coming up. Now, ET tubes, a lot of you have probably seen these by now. ET tubes are quite prevalent in the ICU areas. Those that are having a lot of trouble breathing, they will stick those tubes down their throat to help them breathe more naturally. They'll be hooked up to a machine. And X-ray is very involved, well, really with all three of these, because we do a lot of chest X-rays to check for the placement of these primarily. But let's talk about the ET. I'm sorry, we're talking about ET tubes first. I lied to you. ET tubes first. That's going to be whenever someone needs mechanical ventilation or oxygen delivery in an emergency situation. Mechanical ventilation or oxygen delivery in emergency situations. Also, some of the other indications are listed right there in front of you. If they're having some inadequate arterial oxygenation, parenchymal diseases, an upper airway obstruction, it might be something actually stuck in their trachea. They're going to go ahead and do that ET tube to get some fresh oxygen in there. Gastric acid reflux or aspiration, and something that's called tracheobronchial toilet lavage. Don't worry, that's not referring to an actual toilet. That's just terminology for another condition that people face in the realm of not receiving proper oxygen. Now, no matter what condition, no matter what's going on, when they place an ET tube, one thing that you can make a surefire bet of is that you're going to be called for a chest X-ray. They rely very heavily on us for doing these ET tube placements, because the best way, even though they may do the method of putting that stethoscope on the stomach and listening, so on and so forth, the radiographs are going to be the most accurate measure for checking ET tubes. Now, ET tubes are going to be different from those NG tubes. Don't mix those up. If you remember, the NG tube went down your nasopharynx, esophagus, into the stomach. ET tube is going to be primarily in the tracheal area. It's not going to go all the way into the lungs. Some people think that it goes all the way down into the lungs. We actually don't want that. It needs to be more so in the midway portion of the trachea. I'll show you what that looks like on some radiographs. But once again, our most accurate way of making sure that is in the correct place will be the chest X-rays that we do most often, portable chest X-rays specifically. I've probably done more chest X-rays on the combination of NG tubes and ET tubes than anything else in my career, just because they rely so heavily on using us to check those placements with those chest X-rays. And that's what it's going to look like right there. So the ET tube is going to be what we see right here going down, that little line there. And like I said, it's not going to actually go all the way into the lungs. It's going to be more so close to the bifurcation of the trachea, which is right here. Now, if that goes into the lungs, that's actually advanced too far, and that can cause a lot of issues because it's only helping one lung if it's down there in the bronchioles. We actually want it close to that bifurcation so that oxygen can evenly go into both lung sides and fill them up properly. So if it is advanced too far, once again, that's the wonder of having that chest X-ray. They're going to quickly move that tube back to make sure that placement's in the right spot. Very important to get that fast because it goes without saying we got to have oxygen to live. If they're not receiving that oxygen, they could expire a lot quicker. So something that has to be done very quick, by the way, when you're doing these chest X-rays, you got to get in there and take those X-rays really fast because they got to confirm that placement very fast to make sure that patient is getting proper oxygen saturation levels. And this patient has pneumonia, by the way. That's what that's pointing to. The pediatric chest, by the way, infants. So let's talk about the thoracostomy tubes again. This is going to be a review. We talked all about this in that first chapter. If you remember, the thoracostomy tubes can also be referred to as chest tubes. And there's those same exact things that we talked about before. There's all of our clinical indications of why we might actually need that chest tube. Of course, draining that intrapleural space of fluids. If there's excess fluids or air in the chest cavity, it's going to draw that out. It works by using negative pressure. By the way, where does that box that collects that fluid need to be for those thoracostomy tubes?
At the bottom.
At the very bottom, that is correct, because it's going to use that negative pressure to draw that fluid and liquid out of the body. If we hang it higher than the body, it's going to actually go back into the body. So we want it below so it can drain outside the body. Atelectasis, pneumothorax, hemothorax, pleural effusion, emphysema. We already talked about those, but that's all your clinical indications for those chest tubes, also called the thoracostomy tubes. And if you remember, there is an exact location that we most often will place those. The most common location is going to be between the 5th and 6th intercostal spaces. But if you remember, there was a range. It can be as high as that 4th intercostal space and as low as the 8th, even though the most common will still be that 5th and 6th intercostal space. So it is going to vary depending on what the location is, where that pleural effusion is, where that emphysema is, where that hemothorax is, whatever condition they have. They're going to make those small, fine adjustments into those different intercostal spaces to make sure they're draining it all properly. And if it presents in their location, they'll actually remove that tube and put it in a different location to accommodate where that fluid might have moved, because it doesn't stay in one place particularly. It could move around. So they're going to make multiple adjustments as they need to get that lung cavity completely cleaned out and free of any of those infection-causing agents or bacterium. But definitely remember those numbers. They come right back. This stuff repeats a lot. We talked about this, but make sure it's fresh on your mind. There's going to be a lot of repetition moving through these various chapters of the different things we've talked about throughout the semester. And is this an aseptic or non-aseptic technique? Anybody remember?
Non-aseptic?
So it's actually going to be aseptic. It's going to be aseptic because it is a very risky area as far as infections go. So don't forget that fact as well. It's an aseptic technique. In fact, the one we're going to talk about as well with the different the chest lines, that's also going to be an aseptic technique because it can really result in some very bad infections if we're not practicing that sterile technique. So CVPs, they're called central venous pressure lines. There are multiple types we're going to talk about. So these are the catheters that are actually inserted into our large veins. The most common being the subclavian vein, to be specific. I'll show what that is in just a second. But they're going to be what we call central venous catheters and venous access devices. Now, the main reason that we're going to put these CVP lines into a patient is primarily if you want to administer different drugs to the heart, the veins, the arteries, all the above, or one or two. But also to manage fluid volume, it's going to serve as a conduit for blood analysis and transfusions, and of course monitor the different cardiac pressures. But the main reason would be the administration of drugs. That's going to be a very reliable method. You may have seen some patients with these lines where they actually inject the drug into that vein. It's a very easy access point to get that drug to the heart as fast as possible, instead of just ingesting it or going through another vein in the arm. It's going to be a quick, reliable way to deliver those drugs very fast, very efficiently. Primarily for those who are having a lot of heart issues, vein issues, artery issues, heart attack, people, all the above. That's going to be a very reliable means of getting those drugs to those patients to help monitor their situation, and hopefully if they are having something like tachycardia or bradycardia or blockage, whatever it is, these drugs will help manage that problem without having to actually go to surgery. So there's the subclavian vein right there, right where the clavicle is. That's going to be the main insertion point for these CVP lines, no matter which type we're talking about. It will be inserted close to the shoulder, right by the clavicle, and that's going to be advanced all the way into the heart. And this is another exam, another procedure where we're very relied upon, whether we're doing chest X-rays or fluoroscopy with the C-arm, because they want to make sure that's in the exact right spot, because if it's not directly in the heart, those drugs are not going to be administered properly or fast as it needs to be. So you'll be very involved on these kind of surgeries. In fact, we get called to do these C-arm cases quite a bit, especially with PICC lines, to make sure that line's actually been advanced to the proper area of the heart. And even then, after the surgery, they're going to call us for those chest X-rays just to double check, because it's a very, very vital procedure to make sure it's in the right spot. Otherwise, those drugs are not going to do what they need to do in the proper fashion. So we are very heavily involved. That line coming out right here, this is not internal, by the way. This actually hangs outside the patient. This line here is actually inside the vein. Right here, this is all on the exterior surface of the skin. And they can put that syringe on the very end of that cap and actually administer those various drugs that they need to get to the heart as fast as possible. But even though they may use different veins, the most primarily still going to be the subclavian vein. That's the most direct access into that chamber of the heart, into that atrial area. But if they have some issues with that subclavian vein, they may opt for some different areas as well. But that's still going to be the most common way it's done. I do remember there was this doctor in the OR. I used to call her the butcher, because she would do a lot of these line studies. And for whatever reason, this doctor always nicked the veins. And if you've ever seen a surgery where they've actually nicked a vein, blood sprays out of that vein like a water fountain. I mean, it goes everywhere. And I always just called her the butcher, because I swear every time I got through with one of her cases, the room looked like a horror scene where there was blood all over the floor, all over the table, because she always nicked veins every single time. Every single time. And there's blood spraying all over the place. Would not advise her for my kids or your kids. I don't think she works there anymore, though, so don't worry. At Texas Children's. Okay, so for CVP lines, for administration of drugs, guys, when we're talking about the types of drugs, most of the time this is going to be referred to for chemotherapy and parenteral nutrition specifically. But it's also going to have to do with a lot of those heart drugs, fluid volume. This is a lot of repeat. We just talked about this. The different blood transfusions. If a blood transfusion does occur with a patient, they're going to put these CVP lines in to help regulate that body, receiving that large amount of blood, getting that homeostasis back achieved, and monitoring the different cardiac pressures, make sure it's all regulated in the nice equilibrium homeostatic state as well. Now, when we talk about CVP lines, they were first developed by a company called Broviac, later Hickman, and a lot of their names will be used in a lot of this equipment. But the main three CVP lines that I want to talk about here specifically, guys, are what's called a portacath. Now, portacath is the one that's mainly used for chemotherapy. A portacath is a line that goes into the subclavian vein, but it's very distinct in that it's an actual little bulb that's under the skin. And that bulb, you can actually see it protruding through the skin. And what the nurses or doctors will do is when that patient needs medication, they'll take a needle and actually put it into that bulb through the skin. It goes inside that bulb and then delivers directly into the heart. PICC lines are short for peripherally inserted central catheters. Those are used a lot in pediatrics. That's the ones that I did the most of, because they're used a lot on your neonatal patients. to help deliver those drugs to their heart very quickly. And then Swans Guns catheters, not quite as common, but that's another one that's used a lot as far as CVP lines specifically. So Portacath is primarily for chemotherapy. PICCs are going to be used a lot in pediatrics. Swans Guns is just an alternative type of catheter that's used in a lot of our patients if they don't require the other two that are listed there. But we're going to talk a little more about them specifically here. And all three of those do fall in that category of CVP lines. I'll slow down. I know I'm talking fast, guys. The coffee kicked in strong this morning. All right, this is what I talked about earlier, guys. No matter which one of these lines that we use, once again, that most common insertion site is going to be that subclavian vein, which is found right over your clavicle, up in your shoulder. Now, the alternatives I talked about, the most commonly used alternative veins that they're going to use, should that subclavian vein be inaccessible, would be the internal jugular and the femoral veins. You know, internal jugular is right there at your neck. That's what you feel a lot of times when you're checking for that pulse, that jugular vein. And femoral veins are actually going to be located down in the femur. That'll be another alternative because that femoral vein is quite large. That's when they can easily run that line through. They have to run a lot further, obviously, because that's a very far away location in comparison to the heart. That would be an alternative that they could use. Now, as far as the types that they may use, guys, they come in three varieties. That's what we call single, double, and multi-lumen. It's about the ends of those lines, how they separate. They come in single, double, or multi-lumen varieties. As far as a position, the exact location that we want that to be is right before it gets to the heart, right above that opening of the right atrium specifically. It's going to be 2 to 3 centimeters above that right atrial opening. As far as the path, it does pass through the superior vena cava, not the inferior. So you got to trace it all the way up and through that superior vena cava, depending on which location you're using. But that does need to end right above that right atrium, not directly inside of it, right before that opening occurs. It's going to get that medicine to that heart very quickly, very efficiently. So once again, that's why that subclavian vein is the most often used, because that's going to be the closest to that location without having to trace a very long line through those veins. Jugular is not too far, but it is going to be a little further. And then femoral, of course, that would be the least favorable because that's very far. It's down your leg. It's going to have to be traced quite a distance up to that superior vena cava, into that right before that right atrium opening. But they can do it. They can do it should they need to. And that's just showing you what it looks like in comparison on an X-ray, guys, when it's been inserted into the subclavian vein. Now, you will notice they use the left subclavian vein on this patient. This diagram is showing the right. It does not matter which one. Both can be used. They can both be traced the same way. And when they're tracing that line in, it goes through that superior vena cava, which is right here, that blue vein. And it's going to end right before the opening to that right atrium, which is located right here. Right here. So you can see why we're so needed on the chest X-ray spectrum. You can clearly see that line on the chest X-ray. That atrial opening is right here, and this is placed properly. If that line was down here, all the way close to the ventricle, we'd know they advanced that line way too far, and they're going to need to pull that back very quickly. So whether you're using that C-arm, whether you're using a chest X-ray, they're going to heavily rely upon you to make sure that placement is correct. And then we got to know these locations ourselves, because if you remember, much like other lines we've talked about, if you notice that line's in the wrong location, you want to go to that doctor or that nurse and say, hey, I just wanted to show you this chest X-ray. Look at the location of your line. I just want you guys to be aware of that. Now, you're not telling them what to do. You always got to choose your wording properly. Hey, I just wanted to bring this to your attention of where the location of your line is. Would you like me to stick around while you pull the line back or advance it further? That's very important too, by the way, guys. That's a special recommendation from me. When you become techs and you're doing these chest X-rays, that's part of why communication works so well in your favor. You're going to be running all over the hospital, especially if you're assigned to portables. And the thing I hate the most is I take a chest X-ray, I go away, and they call me right back because they adjusted the line. Therefore, it was always in my best interest if I showed them the X-ray right there immediately and stuck around and said, hey, do you want me to stay here for a few minutes while you fix the line? That way I'm on hand and take your X-ray right away. Now, that's going to save you time and keep you from making multiple trips. And where I used to work, if you've never been to Texas Children's, it's humongous, so there's no quick way to get anywhere. So it was always in my best favor to stick around, to save time. And, it's my job to help them be the eyes to make sure they advance this properly. Because I don't know what's going to happen in between patients. I might get called somewhere else, and they're going to end up waiting on me while they're waiting for me to check that line again. So I would just stick around, communicate, say, hey, you want me to stay here, help you out, check the lines, whatever. But always in your best interest to communicate and show them those X-rays. It's going to save you time and a lot of headache, I guarantee you. Because they will call you right back whenever you've already made a trip to the other building. And I've been there 1,000 times. Used to drive me crazy. Now, Swans Guns. The Swans Guns catheter in particular is a catheter that's actually going to be able to deliver a small electrical impulse on the very end of it. And those are used primarily when they're wanting to just monitor the pulmonary arterial pressure. You notice the pulmonary arterial pressure specifically, that's the only reason they're going to use those Swans Guns catheters. Not used very often, but if they have a extreme condition going on with their pressure, they're going to opt for those Swans Guns catheters. And they're very unique in that they have that little electrode at the very end to help measure that proper pressure accurately. Still going through that subclavian vein, though, but you will see in comparison to the PIC lines and the other one that we spoke of, that goes quite far. It goes actually into the heart and exits through the pulmonary vein on the side of the left atrium over here. And that's because it has those electrodes that can actually measure that pressure. That's the main purpose. They're not going to actually use this as much for administering drugs as they're going to more so use this to monitor the pressure within the blood system and the circulatory system. So that's what those Swans Guns will be used for. Like I said, not used quite as often. If they have a pressure issue, they are going to use those quite a bit. All right, so I already spoke of this, big wall of text there, but we're going to hit the main points. You are very, very important when it comes to all these line placements, guys. In fact, you are essential at the time of insertion, and I put thereafter as needed because, like I just spoke to you, the best thing you can do is stick around, communicate to give everyone less of a headache overall, to save yourself some time. You need to know where these locations are when you become a tech, because it is your responsibility. I know you're not the one actually putting the line in, but it is your responsibility to communicate accordingly to those doctors and nurses. Say, hey, you need to see this X-ray. Look at the placement of your line. Now, would you like me to stick around so we can do some more X-rays as you advance or pull the line back, so on and so forth, what I just said. Now, you're not going to be the one sitting there interpreting these, by the way, but even though you're aware, always be careful with your communication. Like, you don't want to come across as like a know-it-all, like you're trying to tell them how to do their job. I know I hate people to tell me how to do my job. It drives me crazy. But you're still those eyes, and you want to bring it to their attention. What's really incredible is that we have this digital technology now where it shows these X-rays right away. And the way it used to be, you'd have to actually go all the way back to your department after doing a portable X-ray and run these films. And it took forever to communicate it. But now it's so immediate that you can communicate so much more effectively. And as that patient advocate, it is your responsibility with this new technology to communicate this stuff immediately to the right people, alert the right authorities, and then make sure that you're doing everything to the benefit of that patient. And what's the benefit to that patient is expediting everything as fast as possible, especially those that are really sick and in critical condition. And how can you do that? It all comes back to that communication once again. Communicate everything, document everything, let the correct people know, and spread the word properly. Don't run away like some of these techs do. They don't want to be sticking around because they're impatient. They want to get back to their seat and play on Facebook. But they'd save themselves so much more time, so much more headache if they just stick around, communicate properly, and they wouldn't have to make so many trips back and forth. I've seen it myself a million times, and I always just shook my head because they just complain. Oh, my God, they're calling me back for another X-ray. I'm like, well, why didn't you just stick around? What was you in such a rush to leave for? It's your own fault. I don't feel sorry for you. Don't be one of those. Don't be one of those. You're not going to be. You're all going to be the best. You will. Let's just give you a couple more pictures of what those lines look like on an X-ray. We always look for that line to be traced through that subclavian vein right before the point of that right atrial opening, which is right here, close to the bifurcation of the trachea. There's one on the other side, going through that subclavian vein right before that atrial opening. Make sure you know that is the correct location. Like I said, because you're going to save yourself a lot of headache, and you're going to help out your nurses and your doctors and your patients overall. Okay, let's talk a little bit about electrocardiography. It's going to be one of the last subjects we talk about in this chapter. We are going to have an entire chapter talking about this on the next chapter on Wednesday, but we're going to go a little bit through it here to kind of preface what we're talking about on Wednesday, even though it's a very short chapter. So obviously when we talk about EKGs or ECGs, we're looking at the vital functions of the heart, its ability to pump properly. We're going to look at those T waves, QRT waves, R waves. We're going to break those down a little bit here in a minute. Now, do remember when we're measuring this actual cardiac cycle, that is focused upon the ventricular contraction. Sorry, my youngest daughter sounds like she just crashed into my door. I don't know what she's doing in there. She's running down the hallway. We are focused upon ventricular contraction, which is systole and diastole, the beginning to the end, those resting cycles. We don't measure the atrial contractions. We're measuring the ventricular contractions. I'm saying that a lot because people constantly forget that. And it's going to actually measure those voltage points because the heart does give off voltage. Yes, it gives electrical impulses off. A lot of people don't realize that, which is why we shock the heart when people are in cardiac arrest to help it get that electrical impulse back pumping properly. Now, those EKGs are going to make those printouts. Many of you have seen those printouts with all the squiggle lines on it. That's what we're going to learn to read. We're going to learn to read those in class and be able to recognize what's normal versus what might be a cardiac anomaly, which there are hundreds of different cardiac anomalies, tons of them. We're not going to go through all of those, but we're more so going to focus on what a normal cardiac cycle should look like, as well as identify all the waves and define what they are specifically. That's what a typical printout would look like. That's showing you the different intervals. We have our P to R, our S, our RQT, our QT, our ST. We're going to break these down here in a second. So that's making no sense. We're actually going to define what these are, and we're going to spend an entire chapter on that in the next chapter. That is the different intervals of that heart actually pumping, polarizations, depolarizations, repolarizations, the resting cycles. All that is found in that one little segment with all those letters. And that's what your typical EKG strip will look like. And you will hear me say EKG a lot. ECG and EKG are synonymous, by the way. They are referred both to the same thing. I prefer to say EKG, but if you see ECG, it means the exact same thing. But this is a normal heartbeat. If we see anything that's really wide or really short, that's the typical cardiac anomalies we might recognize on these EKG strips. So we'll learn to identify that as we move forward here. Now, as far as the cardiac conduction system, there are four major areas of conduction within the heart. We have what's called the SA node, the AV node, the bundle of His, and the Purkinje fibers. I always like the Purkinje fiber. That's a fun word. Purkinje is just a fun word to say. All four of these are what create the electrical impulses in the heart to help it beat at a steady rate. If any of these are malfunctioning, that's where we might have to go in with the defibrillator paddles to make sure it's back on the correct beat. That's where people have pacemakers, defibrillators in their chest to make sure that these things are working properly because they may have an actual condition that creates an issue where one or multiple of these conduction systems are not working or beating properly. But that's the four main what's the only four? It's the four conduction systems we have within the heart. And yes, you do need to know the locations, by the way. That's why I gave you this nice, pretty picture here. The SA node is at the very top of the right atrium. AV node is at the bottom of the right atrium, right before you get to the right ventricle. The bundle of His travels from the right atrium to the left atrium. It's in both. The ventricles, the right ventricle to the left ventricle. It's located in both ventricles. And the Purkinje fibers are inferior to the left ventricle, not actually in the left ventricle. You do need to know these locations of these nodes. Make sure you know they all are contributing to the cardiac conduction system. And we'll label the heart more specifically in the next chapter. So if you don't know what I'm talking about when we say atriums versus ventricles. We're going to go through each of those a little more specifically on our next chapter, as well as the different areas of the aorta, the inferior superior vena cava, pulmonary arteries, all that wonderful stuff. We're going to do some heart anatomy in the next chapter. Now, here's a big wall of text here, but we do need to make sure we understand these, and we're going to repeat these in the next chapter as well. So when we talk about the baseline of EKG tracing, that's what we call the isoelectric line, and that's going to represent the resting membrane potential. So when the heart is resting, essentially, to simplify that, that's what we call the isoelectric line. Now, a lot of waves and complexes here. It's not going to make a lot of sense until we actually put it on the EKG printouts. We're going to go ahead and start by defining what these mean. So we see an EKG strip. Each of those little waves and sections are going through that P to U wave from beginning to end. That's one complete heart contraction of those ventricles. The very first one that we define is what's called the P wave. And this is what we call the depolarization of the atrial muscle cells. That's when they depolarize. We move on to the QRS complex. That's going to be the depolarization of the ventricular muscle cells. So the contraction begins at the atrial area, moves on to the ventricular area. P wave is the first contraction of the atrial muscle cells. QRS is the first contraction of the ventricular muscle cells. PR interval, I see your faces, it's not making a lot of sense. We're going to break this down even better in the next chapter, I promise you. This is just a preface. Don't panic. It's going to make more sense in the next chapter. PR interval is the area that's measured from the beginning of that P wave to the beginning of the R portion of the QRS complex. That's what's called the PR interval. It's another area that's measured on that graph. The T wave is going to be what we call the repolarization of the ventricular muscle, and the U wave is going to be the repolarization of the papillary and Purkinje fibers. And often is not what we call visible. It's more of an invisible area of that entire process. And I see your faces. I see your brain breaking like, oh my God, what is this? Do not worry. Like I said, this is a preface to the next chapter. We're going to define these a lot more clearly. It's going to be a lot more visual. It's going to make sense, I promise you. So don't panic yet. This is just getting you ready for the next chapter. But we will need to make sure we understand these as we move on. Do not panic. Do not panic. Go ahead and start looking over those definitions. They are going to come back again, I promise you. So P wave is the first portion of that entire section, that graph that we're looking at. The U wave would be the last. U wave is going to be more when the heart's resting. P is going to be when it begins the contraction. All this occurs in one single heartbeat. All these little waves and complexes and intervals. A lot going in there for one heartbeat.
I have a question.
Yeah, what's up?
Where do the contraction starts?
It starts at the P wave. All the way, that's when it's like I lost my train of thought. That electrical impulse begins in the heart and makes it begin to contract. That first contraction begins at the atrium and then goes to the ventricular area. The atria contract first, ventricles contract second. So that P wave is that very first initial contraction of that atrial area.
Funny here, Aurora said that she lost connection. I think she's going to try to reconnect right now.
Yeah, that's no problem. It's okay. But to answer your question, Ruth, we're actually going to go through these a lot more specifically in the next chapter, and we're going to break it all down even further. Just make sure you know these definitions for each of these. It's just the main definitions for each of these complexes we're talking about. We're actually going to watch what it looks like as well. Got some little moving GIFs to show you what that looks like. So that's each of the things we just talked about right there. There's the P wave, the PR interval, the QRS complex, followed by the ST segment and the QT interval. Like I said, I'm not going to go too far into this yet. This is just a preface for the next chapter. We're going to break all this down even further on our next section. We'll learn all you ever want to know about those. So each of these EKG readers have their own style and sequence for interpretation. In other words, they all have different visuals for the way they print these out. Don't let that fool you. They still generally going to show the exact same thing. They just may use different colors, different labeling, different looks, different styles. And they operate under what we call a 5-step analysis. We're going to look through each of those steps to make sure that heart is beating properly, maintaining a good equal rhythm throughout that heartbeat, and no anomalies or heart conditions are present. If we go back here, and I'll give you guys a story on this on Wednesday. My wife has prolonged QT syndrome, which means her Q to T interval goes extraordinarily long, spreads out very far. Thus, she has to have a pacemaker defibrillator to keep her heart on track to have that normal QT interval. Very rare condition, but very life-threatening had she not had the device put in. Her heart does some really weird stuff. I've seen a lot of her EKG printouts, and her rhythms are all over the place. In fact, sometimes she scares me in the middle of the night because she'll wake up because that defibrillator will shock her. It'll make her wake up. She gets shocked in the middle of the night sometimes to get her heart back on track. All right, so in conclusion, guys, with all this wonderful stuff we talked about, now, no matter where you go, no matter where you work, whether it's hospital, whether it's clinic, whether it's wherever, maybe you're going to be traveling overseas, maybe you're going to be going to people's houses doing portable Xrays, which you can do, by the way. That's a very cool career option. Vital signs are very critical, and we must observe and know all about these vital signs, what the average numbers are, what we're looking at, because the primary thing is, even though we may not be directly involved, we still are involved to some degree, because it's up to us as techs, as healthcare workers, to communicate when we see something that's outside a normal range, whether it be blood pressure, respiratory rates, EKG readouts, line placement, ET tube placement, all this stuff we talked about. We've got to be able to recognize it and communicate it properly to the people we're working with. That is our responsibility. That is our job description to do that. And if you don't know and you don't care, it can actually get you in trouble down the line. So very important stuff. A lot of information thrown at you. Main thing is we got to be accurate with it no matter how we're involved. Make sure we're recording it accurately. Make sure we're documenting accurately upon epic when we're documenting our exams, and making sure we're communicating accurately to those around us. So one of the biggest pies in the face moments would be if you think you know what you're talking about with a line, it's actually in the correct spot, but you didn't remember where it's supposed to be, and you're saying, hey, I don't think your line's in the right spot, and everyone's looking at you like you're crazy. So you definitely want to know where those lines should be located. You want to know what you're saying, if you're saying blood pressure is high or low. Otherwise, everyone's going to look at you like you lost your mind. You're going to lose respect of your colleagues. So definitely remember these numbers. And not only for that, the registry, like I've already stated at the beginning of this chapter, loves to ask about this information. They'll throw just one random number at you saying, what's the average BPM for an adult? What's the average BPM for a child? What's the average respiratory rate for a child versus adult? Whatever. Commit these to your memory. Like I said before, what people tend to miss the very most on the registry is primarily patient care questions, because it's usually at the very beginning of your education, like we're doing now. It's generally not the most difficult classes, so people don't take it seriously. We forget about it, and we get to our registry, and that's the questions we miss the most. So very important stuff to make sure you remember. You're going to get a lot of questions on your test in regards to those numbers, in regards to averages, in regards to placement. So start studying now. I would say this is probably one of the more difficult tests coming up in this class, just because there's a lot of numbers flying at you. People hate numbers. I hate numbers. We do have to make sure we know them and memorize them correctly. Let's prepare ourselves for the registry that will come faster than you think. So I know on your faces you're saying, please, for the love of God, will you stop talking about this stuff? Oh, I can read you like a book. I'm telling you, I see it all over your faces. That is going to conclude this chapter. And hang on one second here. Are there any questions on what we talked about for this chapter? Any questions? All that information, it's a lot of it. It's all fair game for really good questions on your next test. Like I said, this is going to be one of the more difficult tests in this class. So I would start studying now for that test that's coming on Friday. But do keep in mind, we have another chapter that we're adding to it very soon. We're going to go through more of that heart information. We're going to talk more specifically about the heart anatomy, how it works exactly. We'll talk more about those EKG sheets and what's actually happening, which each of those intervals and sections, QRS, QT, all that wonderful stuff. We'll give you guys some good visuals to help you study for that. So do not worry if it made no sense. It'll make more sense on Wednesday. So we are done a little early today. Are there any questions on what we spoke about today specifically? All right, well, enjoy yourself a little extra 15 minutes this morning, guys. That will conclude class today. I will see you all at 1 o'clock sharp. Please have your Play-Doh ready. I hope you acquired some Play-Doh because we're going to have our challenge to begin the class in Red Pro to see who will earn the 2 bonus points this time. All right, guys, I will see you all soon. I will see you all at 1 o'clock. I'll send you the PowerPoint, by the way. Bye-bye.